back at it again. Hopefully you all had a great lunch. I know I did. It was very kind of warm out there. All right, so I want to return briefly to talking about calcium. And prior to the lunch break, I had mentioned that albumin and calcium have a relationship, right? And this is most notable in the setting of hypoalbuminemia, when the albumin level is lower than normal. So first of all, let's just define what normal calcium and normal albumin levels are. So the normal calcium, or what we call the total calcium, is 9 to 10.5 milligrams per deciliter, right? That's a normal total calcium. Now, of that total calcium, there are two forms of calcium that exist. There's calcium in its kind of its elemental form, and then there's calcium in its ionized form, right? So if calcium is an ion as an electrolyte, we say that it's an ionized calcium, and when it's in its elemental or its non-charged form, where it hasn't lost its electrons, we say that it's non-ionized. So when we look at your run-of-the-mill total calcium, we're looking at a combination of both is really kind of what this is telling us here. All right. So this is a normal calcium here. And what happens is, if your albumin levels get low, right, a lowered albumin level will actually impact the amount of calcium you have in your body. And more importantly, what it will do is it'll kind of cause an increase in the ionized calcium, which is kind of the important part when it comes to neuromuscular irritability that we can see in hypocalcemia, like we talked about prior to lunch. So what we need to do is, if somebody has an abnormal calcium, right, so you look at their calcium, it's abnormal, particularly if it's abnormally low, all right, we need to look at the patient's albumin and see if the albumin may account for what we're seeing here, all right? And we need to do a correction. We need to actually correct for that albumin if it's abnormal. And so the corrected calcium formula is 0.8, okay? And then 0.8 gets multiplied by the normal albumin, subtract the patient's albumin, all right? So 0.8 times normal albumin, subtract patient's albumin, and then that gets added to what the total measured calcium is. So let's just work through an example. All right, it seems kind of weird here, but let's just work through an example. All right, so first of all, the normal albumin is 3.5 to 5.5 grams per deciliter. All right, that's what we would expect a normal albumin level. So what we tend to put in this part of the equation for normal is 4, because 4 is kind of right in the middle, right? That should be what the normal albumin level is, all right? So we can rewrite this equation as 0.8 multiplied by, and then in brackets or parentheses, 4 minus the patient's albumin, close bracket, plus the measured calcium, the measured total calcium. All right. So this is the functional formula that we'd use to correct for calcium. So let's say that you're working in the emergency room and you're taking care of a patient, and maybe this patient is ill, maybe they're critically ill, and the lab calls and says, hey, I need you to relay this to the doctor. I have a critical level. And they will do that. Lab will actually call the emergency room and tell you if they detect something critical, like critical potassium, critical sodium, critical calcium, these critical, potentially life-threatening alterations they will call in, right? So they tell you, okay, the patient's calcium is critically low. And okay, what is that? And they say that the patient has a calcium of, let's just say 6. All right? So the measured total calcium for this patient is 6 milligrams per deciliter. All right, that's low. Okay, fair enough. So you okay? Well, it's low. So what do we need to ask ourselves?
What's the albumin?
What's the patient's albumin? And then the lab reports to you, oh, the patient's albumin is 1 gram per deciliter. All right? Is that high, low, normal? What is that? That's pretty low, right? We would expect their value to be about 4 grams per deciliter, right? Okay. So then now what we need to do is we need to ask ourselves, am I really super concerned about that calcium? Well, let's correct it based on the patient's albumin. Right? So let's plug in the formula. 0.8, okay, in the bracket, 4 minus, what's the patient's albumin?
6.
Patient's albumin.
1.
And I should, good. The patient's albumin is 1 gram per deciliter, close, and then plus measured calcium. What's the patient's measured total calcium? 6 milligrams per. You guys okay with that? Okay, so this is going to equal the corrected calcium. All right. So now the question is order of operations, right? This is a formula. What do I do first? Good. Do stuff inside brackets and parentheses first, right? So let's do this first. What's 4 less 1? You guys okay with that? So this is 3 within brackets. 0.8 is going to come down plus 6 milligrams per deciliter. Okay. Order of operations. What do we do next? Are you guys okay with that? This gets done next. All right. So what's 0? What is the product of 0.8 and 3? 2. You guys okay with that? 2.4. 2.4. The plus comes down, 6 milligrams per deciliter. You guys okay with that? So what's 2.4 plus 6?
8.4.
That gives us what?
8.4.
All right, so that gives us a corrected calcium of 8.4 milligrams per deciliter. All right. So if we had not corrected for it, right, we would think that it was much lower than actually is the case. Does that make sense? So this is still a little low, right? But this isn't 6 milligrams per deciliter low. Does that make sense? So hypoalbuminemia does impact the calcium. And so that's why we do want to take albumin into consideration. You guys okay with that there? All right. Good. Now, does it matter? Are we necessarily going to be concerned about correction if there's a history and physical exam that suggests hypocalcemia, the patient has positive Shavastic sign, positive Trousseau sign, right? Then what? Well, that's pretty strong evidence that we have a calcium problem. We just go ahead and treat it, right? Does that make sense? But often, as is the case, often you're going to get a call and your patient may not have really substantial signs and symptoms, and the lab's going to call you and they're freaking out like, we've got a panic value, the calcium is this, right? And in that case, it's like, well, the signs and symptoms aren't very severe. Let's see what the corrected calcium is. Do I really need to aggressively get on this or not? Does that make sense there? Okay, cool. All right. Am I okay to erase this? Or? All right. Excellent. Another area where this may come into play is in interfacility transfers, right? Most of you guys have probably been involved in interfacility transfers. Let me ask you a question, and this isn't anything to feel bad about, but how many of you have actually taken the time to really go through your patient's labs before you?
I have, but I don't know what the hell it means.
You don't know what the hell any of it says, right? So hopefully, I'm now giving you guys some tools for, okay, you've got a patient with pancreatitis and they're septic and they're in DKA and maybe they have some ARDS going on and they have all these problems, and you can start looking at their labs and go, oh, look at that calcium. Oh, look at the albumin. Okay, that's not so bad. Oh, look at this potassium, and actually start engaging with the ER, the IC, or the med-surg staff and say, hey, this patient has a panic level hypokalemia, right? Do we have potassium supplementation? Do you want to order a K run of potassium to be administered during the transfer, right? Right? You can actually start doing better clinical decision making and interfacing with the staff and actually getting a better, something known as continuity of care. Have you ever heard of that term, continuity of care, right? Well, it's hard to have good continuity of care as, say, an EMT when we're very limited in what we can do, right? Well, we can't really correct electrolyte and fluid imbalances like we can as paramedics. So I'm also giving you tools for that. Okay, so now that we have gone through all that, we've talked about potassium, we've talked about calcium. I asked you guys to read up a little bit on phosphorus, since there is the bare essential information in the textbook over phosphorus, and or phosphate actually. Phosphorus is a polyatomic ion. So the next thing I want to talk about is probably one of the most difficult things to talk about, and that's sodium. Sodium's a tough one to talk about. So let's talk about sodium. So the rule of thumb is what? Sodium imbalances tend to impact which organ or organ system more heavily? The brain, the central nervous system. And the rule of thumb regarding what sodium does is wherever sodium goes, right? So where sodium goes, what follows?
Water.
Water follows. All right, so at the end of the day, sodium imbalance is going to be a water imbalance, right? A sodium imbalance is going to be associated with water imbalance. It's going to cause or be associated with a shift of water into or out of places where we don't want water to go into or out of. Does that make sense? Okay. All right, excellent. So there are two major problems with sodium, right? And remind me, what is the normal value for sodium in serum? 135 to 145 what? Good. Milliequivalents per liter. Excellent. All right. So that's 0.135 to 0.145 equivalents per liter, right? But we just say that milliequivalents to kind of simplify it a little bit. Okay. So in general, if the patient has a sodium of less than 135, right? So less than 135, we say that this patient has hyponatremia. Good. Hyponatremia. Sodium of less than 135. If the patient has a sodium in excess of 145, we say they have hypernatremia. Good. Hypernatremia. Excellent. All right. So these are the two major problems with sodium, hypo and hypernatremia. All right, so let's talk a little bit about hypernatremia first. All right. So again, hypernatremia is a sodium greater than 145. I believe it says 143 in the textbook, right? Whoop-dee-doo, right? So 143, 145, that, anyway, if it's greater than 145, it's definitely hypernatremia, right? Okay. So what does that mean? What does that mean?
There's too much sodium in the body, in the system.
There's too much sodium, and where is that sodium?
Vascular sodium.
Okay, because that's where we're measuring, right? That's the only area of the body we can measure is we can measure there's so there's too much sodium in the vascular compartment. Does that make sense? So what does that mean if there's too much sodium in the vascular compartment?
We have a shift in fluid from intracellular to extracellular.
Okay. Okay. So if I have too much sodium, hypernatremia, right? So here is the vascular compartment, the interstitial space, and then here I have the cells, the intracellular compartment. All right. All right. So hypernatremia is going to be what? It's going to be a lot of sodium in this compartment here, right? And much less sodium in this compartment here. So in a hypernatremia situation, what can we generally say about the blood compared to the cells?
It's hypertonic.
The blood is hypertonic, which means what?
It's going to draw fluid.
Good. That means fluid is going to get pulled out of the intracellular compartment, right? This is what we call a hypertonic deficit. You guys okay with that? Does that make sense? Why? Because this is so hypertonic. Make sense? All right, so we call this a hypertonic deficit. And that's one of the more common issues that we're going to run into with hypernatremia. And I'm going to try to go for big picture concepts here to try to not overly complicate it if I can help it. All right, hypertonic deficit. All right, and there are essentially two major kinds of hypertonic deficits. All right, there are two major kinds of hypertonic deficits. The first kind is where I lose water, so I have H2O loss. So I'm losing water, but I am not losing sodium. Okay? So I lose water without sodium loss. So water is leaving the body, sodium is staying, which means what? It's getting more concentrated, right? So am I necessarily taking on more sodium?
No.
No.
Water.
It's just what remains is getting more and more concentrated. Does that make sense? All right. So what are some things that can cause this? A loss of water without a loss of sodium? Huh?
Medications?
Diarrhea. Say it again. Diarrhea. Diarrhea. Excessive diarrhea. Yeah. Right? Where I'm losing fluid, but I'm not necessarily losing the sodium. I'm just losing the water, right? So diarrhea is really good at causing this. All right. Diabetic ketoacidosis is another condition where this can happen. DKA, right? you're losing large amounts of water, right? And why are you losing water? Because your kidneys are trying to get rid of glucose, right? And the sodium is staying behind. Conditions where I might ingest large amounts of protein. So excessive dietary protein. All right. And another situation where we may see this is in a disease known as diabetes insipidus. Diabetes insipidus. Has anyone ever heard of that?
Yes.
Also known as DI. So there are different kinds of diabetes. All right. Diabetes mellitus is a diabetes that you all know and love, right? It's the common one, right? It's the, right, when we're talking about Occam's razor, that's the common, right, kind of diabetes we run into. But that's a sugar problem, right? Because what does diabetes mean?
Waste.
Yeah, like wasting away. Diabetes it means to kind of waste away. So diabetes mellitus is a sugar problem, but diabetes insipidus is something very different. Diabetes insipidus is a condition where I lose massive amounts of water. So I pee, I'm losing lots of water. And this can be due to a couple of things. A common cause of diabetes insipidus is, or a cause of diabetes insipidus, I should say, is a condition where I quit producing a hormone called vasopressin, also known as antidiuretic hormone. And so antidiuretic hormone is a hormone, or vasopressin means the same thing. This is a hormone that is secreted by the pituitary gland, and when it is secreted, it goes and it tells the kidneys to hold on to water. Right? So if I suddenly quit secreting antidiuretic hormone, makes sense? What happens? My kidneys become leaky, right? And they start leaking water out. The water leaves, but the sodium stays behind. Does that make sense? What can happen there? All right. Another cause for diabetes insipidus is not the pituitary gland, but it's the actual kidney. The nephrons in the kidneys are not able to respond appropriately, and that's something known as nephrogenic diabetes insipidus, right? So perhaps the more common form is the pituitary, is the endocrine form, and if the pituitary quits producing a vasopressin or it gets removed, it's actually fairly easy to treat. You just give people vasopressin, right? And it's actually really easy to supplement. It actually comes in a nasal spray called desmopressin or DDAVP, and then you can, nasal spray it, and then it gets absorbed, and people can do okay. Nephrogenic diabetes insipidus is kind of tough, and it's a lot harder to deal with, and certainly we're not going to be able to really do much about it. But diabetes insipidus is fairly common in head injury patients. Patients who have had head injuries a side effect or a complication of head injury, of head trauma, is diabetes insipidus, is the pituitary gland quits working or doesn't work normally.
Can you see it in like chronic alcoholism, or is it not? Because I know like that ADH is pretty much stopped, right?
What's that?
If you with alcohol, like
It can be,
suppresses
yeah.
alcohol.
So it can be, yeah. It can be seen in other, like really bad chronic alcoholics. There are some different drugs as well that can cause diabetes insipidus to occur. So this is probably one of the more common causes of hypernatremia. Okay, is this hypertonic deficit, is water loss without sodium loss. Another way is where you have too much water, right? So another way you can get it is limited, I should say, limited loss of water without sodium loss, or more appropriately, with excess sodium. And probably the easiest way that this kind of situation can happen is if we just give somebody too much sodium, right? They just get overdosed. They get overdosed on sodium. Right? Maybe hypertonic saline, something called hypertonic saline has been ordered, and they just get too much. Or you give them a bunch of sodium bicarbonate, right? Right, that can increase somebody's sodium load. Right? Maybe we had to give large doses of sodium bicarbonate to treat some other problem, like a tricyclic antidepressant overdose, or we're treating life-threatening hyperkalemia, and we inadvertently overloaded this patient with sodium. And because we're giving them lots of fluid, they're not necessarily losing water, right? All right. So these are kind of the two major problems that we see with the hypertonic deficits. And again, the hypertonic deficits tend to be the biggest causes of hypernatremia. Now, when it comes to sodium imbalances, the speed by which you either lose or gain or dilute or concentrate sodium, the speed by which that happens dictates how the patient presents. So somebody can present with a very high or a very low sodium, but if it took weeks, days, or even months for that sodium to get there, the body can do a very good job of compensating for that loss or gain of or concentration or dilution of sodium, right? And we're actually not as worried about those patients, right? They could have a very high or very low sodium, and we might be able to get away with just medications, oral therapy, monitoring them, and they might do okay, right? But if their sodium levels change more rapidly, on the order of hours to maybe days, these are patients that tend to have more signs and symptoms. They tend to be more critical, right? The problem with correcting sodium deficits, so you can see that there are multiple ways that you can get to, say, hypernatremia, right? There are multiple ways, right? And there are different ways of treating this. And if you don't get it right, you could potentially harm somebody, right? You could potentially harm somebody. For example, if somebody's problem is diabetes insipidus, well, I'm going to give them some IV fluids, right? Let them drink. Well, what's that going to do?
Still give them the sodium.
Well, they're drinking, and what's happening?
Nothing, right? They're just gonna just urinate.
Yeah, they're going to keep peeing, right? They're going to keep peeing, and they're not going to get any better, right? So it's important to try to identify and correct the underlying problem, right? And again, it's going to be hard for us to do, but good history physical exam is going to help, right? Is this a DKA patient? Is this someone with diabetes insipidus? Is this a little kid, right? Is this a 2-year-old kid that's been having excessive diarrhea, and that's the cause of it, right? And they have some sort of they have like rotavirus, they have rotavirus or E. coli or some sort of diarrheal illness. It's really important to try to get a good history and physical exam on these patients. All right. So that's hypernatremia. All right. It's hypernatremia. So let's talk about hyponatremia next. And this is even more difficult. This is a much even harder problem to talk about. Do you guys got this okay? All right, I'm going to erase this. And we're going to move on over to talking about hyponatremia. Before I get into the nitty-gritty of hyponatremia, I just want to mention something. And this goes back to where the sodium goes, the water follows. And this is a caveat that I want to throw at you. Whenever we think about treating sodium problems, all right? And it is rapid sodium correction. We should avoid rapidly changing somebody's sodium at all costs. Are you guys okay with that? We should avoid rapidly changing serum sodium at all costs. It is a rare problem. It is fairly rare, but if it occurs, it is neurologically devastating for these patients. Okay, and it is a problem known by many names, but one of the names is something known as Osmotic Demyelination Syndrome. Have you guys ever heard of that term before?
And this is the result of rapid sodium?
This is a result of us being too aggressive at correcting sodium. Yeah, this is a provider-caused problem, right? And that is osmotic demyelination syndrome. This is sometimes referred as a central pontine demyelinating syndrome or demyelinasis syndrome. Okay. So what happens here is if you cause sodium particularly, and occasionally this can also happen with glucose. If you rapidly correct glucose, particularly if you have someone who's really hyperglycemic and you cause their glucose to drop very rapidly, is where we would see this. So sodium and glucose correction. What can happen is you can cause substantial fluid shifts to occur, right? In and out of cells, depending on if it's a hypertonic or hypotonic or hypernatremic or hyponatremic situation we're dealing with. And what can happen is that sudden movement of water, that substantial osmosis, all right, can essentially blow the myelin off of all the neurons in your brain, right? And what's myelin?
It's like the protector, like the.
Sort of. So myelin is a fatty sheath that surrounds the axon, right? And it is an insulator, essentially. It insulates the axon and allows the signals that the neurons, right, propagate. It allows the signal to move down that axon more efficiently. So what happens is in osmotic demyelination syndromes, you blow all the myelin off of all the neurons within your brain, and then the neurons are not really able to communicate anymore, and what have you done to your patient? Yeah, you might as well just take your patient and pick them up by their hair, dig a hole in the garden and plant them, because you have essentially a carrot or potato at that point, right? You have induced a significant neurological insult to that patient, and generally it's not particularly reversible. Now the good news is it's not common, right? This is not commonly seen. We don't see it a whole lot. But when it does happen, it can be absolutely devastating, and can be the result of being too quick, too aggressive to correct. So when it comes to sodium correction, we only correct it if your patient is having life-threatening manifestations of hyponatremia. And from a pre-hospital context, we only correct it enough to make the worst of those manifestations go away. Does that kind of make sense? Right? So if the patient's hyponatremic and they're having seizures, because that's one of the life-threatening manifestations of hyponatremia is seizures, if they're having seizures, well, we need to do something, right? We need to get their sodium level up, but we only get it up enough to stop those seizures, get that life-threatening thing over and out of the way, and then we back off on our treatment and get them to an ICU where very judicious, slow, and monitored correction can occur. Does that kind of make sense?
And then treatment for hypernatremia?
So treatment for hypernatremia is going to vary.
Okay.
It really depends on what is the cause of the hypernatremia. I wish I could say, oh, it's because there's too much sodium, give them fluids and dilute the sodium out, right? Okay, what if it's diabetes insipidus, right? Giving fluids might make it worse, right? Might make them urinate more. And so in diabetes insipidus, the treatment's going to be, well, stop drinking, stop giving them fluids, right? Hold off on fluids and figure out what the cause of the diabetes insipidus is and treat the cause, right? If it's diabetic ketoacidosis, well then, yeah, they might need fluids, right? Because they're really profoundly dehydrated. So fluids might be very helpful. So it really depends on the context, and that's why I know I keep saying this and hounding you guys with history and physical exam. I can't emphasize it enough, because that's really going to help guide where our treatment needs to be. So it's going to be a very individualized approach that we take. And unfortunately, hypernatremia in particular is going to be hard for us to detect in the pre-hospital environment, because how does it present? Well, it presents, people are tired, they don't feel good, they're malaise, they have fatigue, generalized weakness. Well, that's non-specific, right? These are really non-specific constitutional findings, and right, a whole list of problems can cause that. And so it is inherently a little more difficult unless we're in a setting where we can actually get some labs and figure out what's going on with them. Now, with that said, do we have the ability in some contexts to perform pre-hospital labs?
You're on your service yet?
Huh?
Depending on your service.
Depending on your service, absolutely, right? These are something known as point-of-care lab. Have you ever heard of that? A point-of-care test? Right? A point-of-care lab test. Now, there is a point-of-care test that's fairly well accepted, and you all do them. You do this test all day long. Blood glucose, right? Yeah, a glucometer, right? Glucose is typically done in a lab, right? And it is one of the few tests where we do outside of a controlled lab setting. And when you perform a test outside of the lab setting, we call that a point-of-care test. But there is some infrastructure behind that, right? If you're doing point-of-care test, what does that mean? Well, you need to make sure that your monitor's working, right? You need to run your controls every shift or every day, right? That equipment needs to be certified. It needs to be validated, right? There are some regulations surrounding doing point-of-care testing. Well, guess what? There is point-of-care technology that allows us to run other labs outside of the hospital. Probably one of the more common devices is something known as the iStat. Have you ever heard of that? The iStat. It's essentially a piece of equipment that has little cartridges. And you can have like a little cartridge that measures part of the chem panel, a BMP or a Chem 7, right? And you just draw the patient's blood and you put the little cartridge in, right? And the sample of blood goes in and it'll actually give you a lab. Now, obviously, just like a glucometer, these iStats, they need to be certified, they need to be validated, controls need to be run on them, so there's infrastructure on them. But there are services out there that are actually doing labs out in the field.
What's the cost of that?
It's expensive. Yeah. That's why we don't see services in New Mexico doing it, right? We see like,
No, Van Horn, Texas is there.
yeah, lots of places in Texas, like the Houston area, Herman Memorial, I think. There's some really super progressive EMS services in Texas, Houston, Dallas, where they're actually doing point-of-care tests. One of the big ones is actually cardiac enzymes. We haven't talked about those, but they're running cardiac enzymes out in the field. It is, yeah. But our arterial blood gases, right? There are services running ABGs out in the field, and we'll be talking about ABGs maybe today, but more than likely it'll be on Tuesday. Yeah, they're drawing arterial blood gases and running them. Flight services are using these, right? Because you're essentially an ICU as a flight service, all right? You've got a patient on a ventilator, you've got lots of meds, and You want to know, how's this patient ventilating? How are they oxygenating? What's running arterial blood gas? Okay, this is what we got. Let's go ahead and make some corrections. Or let's say you have a patient with chest pain and the ECG is normal, and you're like, well, do I take this to a cardiac center or not? Well, here in Las Cruces, it's not much of a decision, right? Because both places are chest certified, right? So it doesn't matter. But let's say you're working in a town that has a dozen hospitals, and you can't just take everybody with chest pain to the heart hospital, right? To the chest, right, and overwhelm them, huh?
We're working in Demi.
Well, yeah, then
Right now, our protocol is if there's any sign of cardiac, you err on the side of the patient, but chances are you're gonna found a bill that they don't need.
Exactly. So what do? You default to flying, and probably most of the patients, I would dare say, most of the chest pain patients you're flying probably aren't having acute coronary syndrome. Some of them are, but probably most of them, right? You've got, pleurisy, pleuritis, pneumonia, costochondritis, right? There are a whole bunch of things that cause chest pain. So it makes sense in some services where, okay, the ECG isn't really showing me much. Well, let's go ahead and let's run cardiac enzymes. Oh, the cardiac enzymes are normal? Well, in that case, I think I might defer and take this patient to, just a standard hospital, right? Now, could they still be having acute coronary syndrome? They could, right? But, it's less likely. Or, oh, the ECG, it's not really telling you much, but the troponin's positive. Okay, well, we're going to the heart hospital, right? So labs, they don't make the decision for us, but they help us. They're tools to help us make better decisions. And so we do see these point-of-care tests out there. So there are services where they are perhaps a little more involved in correcting some of these problems. And it's not my job as an educator. It's not my job as an educator to teach you how to be a paramedic here in Las Cruces at AMR. That's not my job. My job is to make sure that when you graduate this program, you could be a successful entry-level paramedic anywhere in the country, right? Which means that I need to talk a little bit about some of the stuff that you may not run into where you work currently, right? It's the same reason why in environmental emergencies I'm going to talk about jellyfish stings. Why? Well, you're not really going to see a jellyfish sting here in New Mexico, right? But maybe if you're a paramedic in, say, Florida or California, working in a coastal community, jellyfish stings might be more relevant there. Does that kind of make sense? Or if I'm in Florida, what are my chances of running into a high-altitude pulmonary edema? Kind of non-existent, right? But here in New Mexico, my chances are a little higher if I'm in Colorado. So I have to be a generalist, so to speak, and give you a general bit of information on things. Okay, you guys good with that? All right, so what I'm going to do is I'm going to put you guys in a little break, and when we come back from break, we will talk about hyponatremia. And hyponatremia is super nuanced, and I want just a whole section that I can just focus on hyponatremia with you guys. So get out of here, take a few minutes, and we'll come back and get through hyponatremia.